What are we talking about today?
Today we're going to be covering a very important topic in terms of its appearance on the exam, and it's one that's applicable to all aspects of EGS, upper GI flavour to it, but we're going to be talking about peptic ulcers and peptic ulcer perforation, more specifically, emergency setting.
Emergency operation setting.
Yep.
So without further ado, Osamah, you're on call. You've had a 35-year-old young man turn up to your emergency department.
Where is he from? What's the ethnicity?
He's from around London. And so he's turned up, background smoker, had 4 days of pain, takes lots of ibuprofen to cope with his long hours of manual labor. And apart from that, no other comorbidities or significant histories. Had 4 days of pain, And you've scanned him. There's free air in the upper part of the abdomen, supracolic compartment. We're suspecting a perforated gastric ulcer. You've consented the patient appropriately. You've assembled your team. You're standing in the anesthetic room to brief before they put the patient to sleep. Go.
So once again, assuming everything's been done as per the ABCD CRIS protocol for people giving the exam, make sure that you start systematically. When you're doing the brief, you'd start off explaining, number one, speaking that anaesthetist about the antibiotics required. So as per trust policy, you go for broad spectrum antibiotics, and antifungal might be appropriate as well if there's an upper GI perforation as well. So ensure, number one, antibiotics are given. You speak to the theatre team about your standard setup. And what I would do is stand in between the legs, as we discussed, ensuring that you have the adequate number of ports. Some use 3, some use 4. Doesn't really matter. Depends on what you're more comfortable with. If there's a patient with a high BMI, consider a liver retractor, can be helpful as well. In this situation, it's as per any emergency laparoscopic procedure where you have saline, wash, suction, ensuring that you have the standard equipment such as Johans, etc., which the scrub team already know. And in terms of how you're going to actually repair the potential perforation, so you would have Vicryl or PDS, depending on which suture you would prefer, 2 or 3 or whichever you prefer. And explain that we go in there and, we will see what it is. If it is, for example, a gastric perforation, you'd explain to the team to have biopsy forceps ready, or so that you can actually take biopsies intraoperatively if necessary. And then you proceed with the actual procedure itself. So it's very essential in this situation that you maintain the principles of sepsis control again that you've discussed on your podcast before. You ensure you get the patient ready, prep and drape as WHO checklist, insert your ports, which have not been left in from the last podcast as we discussed, fresh ports. You go in there, start off in a systematic laparoscopic approach where you look throughout all the quadrants, ensuring if there's contamination. The most important thing with a perf DU or a perf GU is that you get control of the contamination. That means wash, suction, ensure that you've got a clean field.
Okay, just for the purpose of in the exam, you everything you said absolutely spot on and all the marks there. Yeah. But just for the purpose of exam, of course, you want to have some kind of phraseology that'll get you through quickly. So if you are in that scenario where you're parachuted in halfway in a scenario, as in you've already had the examination history, the antibiotics on the ward or whatever in ED, and you've done a CT scan, if they give you that kind of scenario, which they readily do. So you're kind of jumping into halfway, i.e. you're in the anesthetic room prepping.
Exactly.
What you want to do is, again, not be thrown by that and go back to, I get blood gas. So just remember, you play to the scenario, not what you want to start from the beginning. They want you to start here, you start there. Okay, and one way to say is the equipment you've already highlighted. And in theatre, you could say something like, in an adequately prepped and consenting patient who's under general anesthetic in a split legs or however way you want to do it, I would proceed to insert my ports, and again, you could choose however many you want.
3 port, 4 port.
With my first or my main objective initially being a staging laparoscopy to determine the extent of contamination, extent of pathology, suctioning and washing as I go throughout with warm saline. Then once you've done that, then you can proceed to the surgery. Absolutely. So you mentioned quite a few things that was very important, I think. We say perf DU, but or rather perf peptic ulcer. Now, peptic ulcer could be obviously duodenum, it could be in stomach, it could be in both. And they can all come in different flavors and sizes depending where they are. So what would, the scenario thing we gave you was in the stomach. What would you need to be careful of in the stomach? Okay, we know the patient's young, but what are the things you got to be careful of? What you're worried about potentially?
So gastric ulcers have a higher incidence of cancer.
Right.
And what you need to do specifically with gastric ulcers that you don't have to do with duodenal ulcers is actually take biopsies. It's very essential that you do.
Make sure it's
these
not a malignant ulcer.
Exactly. So that's first and foremost. So once you've done the washout, you've identified where the pathology is. If it's a gastric ulcer, once again, you take the biopsies, you send them off, and then you proceed with repairing. And now the repair varies from consultant to consultant, from surgeon to surgeon, but the main basics and the principles is to stop the perforation. And what that means is whether you close it primarily or you don't, you take a bit of momentum and you patch it on to the area of perforation. Or do both. Exactly. And you can do this in multiple ways. So the way that I use in my practice, and when you are speaking in exam terms, as per my senior colleagues who've trained me in the past, have always said, in my practice, so you sound confident. Don't sound like a registrar. You don't want to
say you could do this. They know what you could do. Exactly. They want to know what you would do.
In my practice, I start off using 2 ovicral sutures, 3 stitches, one at the top of the perforation, one at the bottom, one in the middle. I will then find momentum that is mobile enough to cover the perforation, and then I sequentially tie in, and that's basically it, to be honest.
What's that called?
Graham's patch repair. And once you've done that, now of course there's ways they might ask you in the exam, what if the momentum doesn't come up? What else can you do? So there are multiple things. You can patch it with small bowel. I've never done that. It's something you can do. You can use the falciform, for example, as well, which is another option. But the basics of an exam, you just say omental repair in the form of Graham's patch repair.
That is the most important thing, is that you are doing something that you know how to do, that you've done before, not what you think sounds fancy. That's not what they're looking for. They're looking for, remember, this exam is about you being a first aid consultant, and if you had this case, can the examiners be, he or she be confident that you are able to kind of deal with this? And this is one of those topics that doesn't matter what your subspecialty is, we all have to do this as part of EGS, general surgery. So if you've never heard of people patching it with the falciform, don't say that.
Exactly. So you start off with common things being common, but it's also important that as an upper GI trainee, you would do it laparoscopically. If you're not comfortable doing a laparoscopic repair, you do an upper midline laparotomy, and you do the exact same principles in an open approach. So do what you're comfortable with. Don't state anything that you're not comfortable stating. And as is with any, as we said, emergency procedure, sepsis control. The most important thing is wash out, repair the issue, and put some drains in.
Excellent.
And as simple as that.
Excellent. So you've, unfortunately, the patient wanted to test your physiology, and it's a perforated second part of the duodenum. Mm-hmm. How would you treat that?
So once again, same situation that we do, you get adequate exposure. In this situation, if I need to put an extra port in to retract the liver up to ensure that I have adequate space to perform my repair, wash out, see the size of the defects. The size of the defects is very important as well. So in this situation, the guidelines say if it's less than 0.5 centimeter, for example, then you can potentially do this as a patch repair. But if you start going above to the largest ulcers, for example, 2 centimeters and higher, people say that you then have to actually end up doing a diversion procedure in the form of either doing a gastrojejunostomy or putting a Foley's catheter in. The main aim, once again, is sepsis control, but patch repair when possible.
So that's important, because maybe not so much in the context of general surgery, but certainly as a general case, the upper GI trainees may get more questioned on that. Yeah. You've got a small hole. By small, we mean about 0.5 centimeter, not much bigger than that. You just do a primary repair, as you just described, sutures, momentum, both, whatever you want. Yeah. If, however, you've got a great big cut, and they won't give you something borderline, they're going to say 0.6 centimeters. They're going to say like 2 centimeter, great big hole there, which you're obviously not going to be able to reliably close. Then you're going to do an exclusion and diversion procedure, essentially, which means what do you do? So let's say you've got a big 2 centimeter D1, D2 cut or hole. What do you do? So
first and foremost, gain control of the sepsis. So you put Foley's catheter, for example, into your large perforation and bring that out as a controlled fistula. Exactly. And in this situation, what you can also do is do a divergent procedure in the form of a gastrojejunostomy, where you exclude just distal to the pylorus, for example. You can do this in multiple ways. You can get a stapler across, and potentially that way you have the flow going from the stomach into the jejunum that you've diverted, and you've got a control fistula in the form of a duodenum.
Excellent.
That's the way that I
Excellent. So
and drains, obviously,
Yeah.
everywhere. Multiple drains.
Yeah, absolutely. This is, of course, having adequately washed out and the patients. You've identified this pathology. You're going to do an exclusion procedure, and what that means is, like you say, you're going to take the blood vessels down and kind of just before the infrapyloric and suprapyloric.
Yeah.
Be careful. There's going to be some quite densely populated area in terms of blood vessels and important structures. Make sure you're not stapling off the common bile duct or aberrant right branch of the hepatic or just about anything else that can come into view. It's a very dicey area, but so you're going to take your time, kind of retropyloric or retroduodenal, between the junction of pylorus and duodenum. You don't want to impinge too much on duodenum, of course. And you've stapled that off. You now have the two things are separate. Well, you've got to ensure gastrointestinal continuity, right? Mm-hmm. So what do? You just bring up a loop of jejunum.
Yep.
How far along the line? Do you do 2 meters, 6 meters? 5? No.
You keep. You don't have to go too far.
Don't have to get too far. 50,
50 centimeters. 60 centimeters. 50 is the minimum.
Plenty. So you bring up 50 to 60 centimeters, counting from your D3. Essentially, you're bringing it up and you're plugging it into the stomach. So food and gastro juices can go down that limb, and you've also stopped it. You've excluded the pylorus, but you still have a hole in that. Sorry, and you've excluded duodenum. You still have a hole in duodenum. What do you do with that?
So we mentioned about putting forming a control fistula in the form of Foley's catheter, something, or a drain. Just if you cannot get, for example, a catheter, it's quite fiddly, as you have probably seen in your practice, to get a catheter in and hope it stays in place and put some stay sutures, for example. If you can't do that, just put larger drains.
Put a drain in.
Yeah.
If you are able to slightly narrow the gap around it, you can. If you can't safely do it, then don't. Just put a big drain in. Yeah. To keep, and obviously a drain next to it on the outside as well, to have that control fistula. Be careful, of course, if you are trying to suture, whether it's primary closure or you're trying to narrow it a bit so it's a bit more snug around the drain. If you're in D1, D2, ampula's not going to be a million miles away. The last thing you want to do is take a great big cut, stitch and then close off your CBD and you go by.
And on that note, I asked you this question when I was preparing for my FRCS as well. If you're not comfortable completely excluding distal to the pylorus as well, it is reasonable to say that's not your territory. You could potentially just put drains and do a gastrojejunostomy.
Absolutely.
That the main aim is to do no harm. Don't state anything that you're not comfortable doing.
Absolutely.
And refer to centers before you do something irreversible.
In fact, unless you are, if you're not upper GI, if you're not upper GI and still comfortable doing that, and that's fine, you can say it, but because you've done it before, and some colleagues may have done, even if they've done other subspecialties, that's fine. But if you're in any way not comfortable doing that, do exactly what you just described. NG tube to decompress the stomach, a catheter or a big drain into the hole, and then just do a gastrojejunostomy. And if you have to open up to do it, a gastrojejunostomy is to make a hole in the jejunum, make a hole in the stomach, and stitch it together, or staple it, whatever you want to do. If the patient, they may give you a scenario, well, actually the patient's about to crash, really extreme, what are you going to do?
Wash out drains.
Lots of drains, wash out, that's it. Come back and look again tomorrow when there's an HVB or upper GI or whoever colleague is around, if you're not one of those yourself. So always, that's damage limitation, isn't it? And don't be afraid to say that, because it's about getting this patient out of trouble. Let's say you have done that, whether you did a drain, an exclusion, or a primary repair, whatever it was. Patient then goes to intensive care. What are your instructions going to be? That's one of the things I sometimes like asking.
So people get quite worried about putting NG tubes after these repairs, and I think it's absolutely fine to do so if done under, when you're doing the laparoscopic procedure, you can see exactly where the NG is. So as long as you ask them not to push too much on ITU, so you ensure that you mark where the NG tube is in terms of the centimeters from the incisors, and you keep that documented in your op note and explain that nothing should be related.
I agree with you, but I was going to say, I always kind of thought, if your repair is so flimsy that a little rubber kind of NG tube is going to poke a hole through it, you've got far bigger problems.
Let's not test the capabilities of some of our ITU teams.
I've seen you putting an NG tube hitting in that big stomach, hitting that exact spot at a right angle to poke a hole through it is very, very minimal.
But you can ensure that it's not manipulated unnecessarily.
Yeah, so
you can do that.
Steel-tipped NG tube.
Yeah. Can happen. Continue IV antibiotics, continue antifungals. I keep them on IV PPI. There's there's evidence of this is scarce, but that's what we do in clinical practice.
Eradication.
H. pylori eradication essential. And once you've done that, you ensure that you have to look at nutrition. The patient needs to heal. And so when you look at this, you're not just looking at repair. You want the patient to actually get better.
Generally,
exactly. So in this situation, you have one of two options, as you do with any form of nutrition. You have enteral and parenteral nutrition, and you decide based on your MDT approach with your ITU colleagues as to how you proceed with that.
Yeah, excellent. So, and again, you need to, everything you said absolutely right. And we're just doing this in a discussion, but in the exam, what you want is a really practice, but not completely robotic, artificial kind of overly rehearsed answer. But you want to say, my post-op instructions will center around the immediate clinical aftermath, the working in MDT to provide adequate nutrition, early mobilization with the help of the physiotherapy team, dietitians, anesthetic and ICU colleagues, and then you talk about each one. So, from the clinical GI perspective, you want PPIs, eradication therapy. You want to make sure they've got VT prophylaxis, DVTs. It sounds really basic, and I know it is. And I know all of you do that in real life, but honestly, these are the things that tick the checklist. So please do mention it. And you want established feeding with the help of dietitian team. Now, they may be that may be an NJ tube, and you could say if you've got experience with a triluminal, for example, you can. So that's 3 lumens. One sucks up the kind of the juices from the stomach, and the other one goes distally beyond your repair to do it. Now, if you've excluded it, you don't really have that option unless it's completely OGD kind of guided, and you got to go down the right limb. But
it's easier for our gastroenterology colleagues in that situation.
So yeah, exactly. So you need to say you work in that MDT. You said,
is there anyone we haven't offended yet? What's on the checklist?
Where did the dermatologist?
I'm keeping tab. We haven't mentioned dermatologists.
We'll find a skin rash.
We'll get this.
So it's important that we work in the MDT and to address all of that. The other thing they may say is that you may be a planned return to theatre. Like you said, first of all, if you're just going to staple everything off, or not necessarily in this scenario, but if you're just going to do damage limitation, you've got to have a plan to come back, because you don't want to be prompted for that and lose a half a mark or something. Fine. So that's what you'll do on the in the scenario immediately after surgery. What about then? They may ask you to fast forward down into the future, and the patient comes back to clinical. What other procedure you may do, for example, OGD and stuff to check healing. So you would probably, if you haven't already done it, you would need to do a scope to look for healing. Yeah. Obviously, you're going to look at the histology as well.
Or further down the line, they'll come and tell you the patient's now got bile reflux.
Right, excellent. Yeah, so that's the other thing as well.
On that check OGD, you found lots of bile and they've got GIM on the histology.
Yeah, exactly.
What are you going to do now?
And that is going to be very much for a long case for an upper GI specialist, subspecialist, not an EGS scenario.
Which means you're doing well.
Normally it ends up coming, as you know, in the 5-minute scenarios, usually in the exam. Perforated ulcers, it's one of the shorter scenarios, but it can link into the long ones as you
It will be. But ultimately, these scenarios are going to, like the time, like you say, it goes by really, really quickly. There's no way you're going to be covering all of them. Yeah. Concentrate on the part, but you need to have that concise kind of, and it's not, okay, some of us are, some people are better at articulating themselves than others, especially under pressure, but ultimately just practice.
Absolutely. Yeah, absolutely.
And you got to practice it and time yourself.
And it is not unusual what you mentioned being put into this midway through the scenario, and what our habits are by practicing, for this exam is to go back to the start. You don't waste time. You have limited time. You need to maximize the point, get your points across, and if they need it, they'll prompt you.
And sometimes they'll put you back in time.
Absolutely.
So there's also something like, this is a patient that you're on call of the weekend, it's been handed over to you, and this is a scenario, perf DU or brother has got abdominal pain, has now got a perf DU following some other high-risk kind of procedure that was done unrelated to it, and you're taking him back. And they may ask you something like, oh, so it was noticed 4 days ago and there was a tachycardia 2 days ago. What do you think about that? And they may ask you to go back in time. And obviously don't bash colleagues. That's not your job. That's your hobby. So you got to give it to someone. So be professional and just comment on the scenario, what you would have done rather than they should have done this or they should have done that. But it's very possible they shift you back and forth on time.
Also, all right, here's another twist. It's same patient having that check OGD by a colleague, and they've hit the there's noticed a lot of bleeding coming in from D2, and they've tried the spray and pray method of two attempts of endoscopic stops, and now they've called you to take the patient back to theatre.
Presumably this wasn't caused by another colleague who did the RCP before.
So what are you gonna do?
So
D2 bleed.
So D2 bleed, once again, you have the patient prepped, stand between the legs, ensure that you're using new ports.
You do this laparoscopically.
In this situation, I would potentially start laparoscopically, where I would have a look and find out exactly what's going on. Right. There's no harm in doing a laparoscopic approach and then converting to open. If you're more comfortable doing open from the start, you can do so. If you have bleeding, and which is uncontrolled bleeding, as you very rightly mentioned, it is difficult to manage laparoscopically. So you could then convert to an open procedure. The main area of bleed in these situations is the gastroduodenal artery, which can be passing, as you said, towards the posterior aspect of the duodenum, and ulcer eroding into this. So what you actually have to do is find the area of concern, ensure that you open the duodenum up, find the area of bleeding, and in this situation, it's the principles of getting hemostasis in any surgery. Get a stitch, put a Z stitch, or whichever stitch you prefer, and stop that area of bleeding. Put swabs, control the bleeding, ensure that the anesthetist catches up. Now, it's very important in the exam scenario to also mention that you are in regular contact with the anesthetist. You're not just focused on operating. So you need to allow them to catch up. If they've lost blood, how much blood have they lost? Have they got clotting product? Have you put out a major hemorrhage protocol? These are all important things you need to mention as well. Get the transfusion on, get control of the bleeding. Nowadays, you have many hemostatic agents as well in the form of Verised, for example, which you can also use to help control the bleeding. But it's the principles.
Other products are also available.
Yeah.
But
other products are available, of course. Yeah.
It's the principle of hemostasis. So open up the duodenum with this laparoscopic open. Again, be careful of the ampulla, because that's the one thing you want to mention. Because if you don't mention something like that, say, oh yeah, great, so patient's over after day 2, the bilirubin is now 155, or that you close off the ampulla. That's what they'll go for.
But they're not dead from bleeding.
See, this is what we have here on the show, though. It's a silver lining.
He makes some really
dying from liver failure.
They need a liver transplant, but they're not dead.
By then, you're off the on-call. It's not going to be a problem.
It's Cambridge's problem. It's not my problem.
It's that kind of team building scenario that we have you on the show for. So be wary of the ampulla. At any point, look, obviously, it's a very difficult area to work in. Get hemostasis. Now, of course, that scenario would have been after you would already have tried various other techniques like endoscopically or and kind of radiological.
Yes. Which is an important thing to mention.
We would also
radiological and interventional radiology are key in the situation.
It depends what they ask.
There's BSG guidelines for that.
Yeah, exactly. And you got to be aware of those BSG guidelines. So if they're already, you wouldn't say, "Oh, just take it to theatre and do this." If they're asking you from a scenario, what are your options? This would not be your first option.
Yeah.
It's only if they, like you say, parachute you into. Oh yeah, we tried twice OGD. Yeah, we've tried angio in an expert interventional radiology hands, and it still hasn't been. And still bleeding, you've not been able to do it, or it's 2 o'clock in the morning and they're about to die. And you have from blood loss, and they push you and you have to go to surgery. They want to know what you can do. That's the principle, really. You open it up, good communication, blood products, not just hemoglobin, packed red cells, but other products as well, in conjunction with your local protocol and hematology. So simultaneously resuscitating the patient. Pair it in the manner you talked about, Z stitch, interrupted, doesn't matter. I think people get a bit too hung up about those things.
But just in my practice, I do this.
What are you used to, what are you comfortable with? It doesn't matter if you do a Z stitch or not. It doesn't matter. Absolutely. What matters is your objective is to control bleeding.
Absolutely.
How you do it doesn't matter.
Absolutely. And you mentioned guidance. If you're going to mention any form of guidance, please know the guidance. I'm sure you've mentioned this many times on your podcast, but it's very important because they will ask you. Sometimes it comes across as confident, they don't, and they give you the higher marks thinking that you know the guidance. Yeah. You will be caught out if you don't know.
Yeah, it doesn't look good. And it doesn't mean necessarily you need to know every word of a 90-page document, but you need to know the gist of it. Exactly. You need to know what the gist of it is. But yeah, that's how you control the bleeding. And in the same kind of slight twist is perforations after ERCP, which can happen, and you get different types. But we kind of covered this before.
We did the classification.
We did, yeah. We're not going to do the classification again, but for those of you who are HPV and upper GI, yeah, you're real for But for those of you who are upper GI or HPV trainees, you certainly need to know those classifications. But they may ask you a scenario like that which requires surgical intervention, maybe from the word go, or actually you started conservatively and they're getting worse. And it'll be a similar principle. If you can't stitch anything because everything's friable, whatever, drains. Drains are great. Foley, drains, everything, teach you whatever you find. Doesn't matter. Just drain as many of it as you can. Control.
I think that's it.
I think that's it. Someone, anything that you want to add?
Thank you guys once again for having me.
No worries.
It's a pleasure.
Thank you.